Welcome to the ICU podcast, where we explore the vestibular experience through conversations between patients and the health professionals who care for them.
During this podcast, we invite patients to share their stories and healthcare professionals to ask questions so they are equipped to better care for and truly see the invisible challenges faced by their patients. I'm Kimberly Warner.
And I'm Cynthia Ryan, and we are your hosts on this journey of discovery. Hello, welcome to a new episode of the ICU podcast. Today, we're going to talk about how the brain interacts with the body and one specialized type of healthcare provider who studies this. Chiropractic neurology, also known as functional neurology, is a specialty that branches from the traditional chiropractic methods. You might think of a traditional chiropractor as someone who performs manual adjustments on the neck and spine. Chiropractic neurologists aim to optimize neurological functions by leveraging the concept of neuroplasticity, which is the brain's ability to change and adapt. Chiropractic neurology offers a holistic approach for assessment and therapeutic interventions that may benefit some patients with vestibular symptoms. By looking at how brain function intersects with other systems in the body, chiropractic neurology can begin to unravel complex health conditions. Today, we're going to learn more about what chiropractic neurology is and what it isn't by speaking with a chiropractic neurologist and one of his patients. So I'm excited to start by introducing Dr. Demian, who has a bachelor's degree in kinesiology and a Doctor of Chiropractic degree with postdoctoral studies in chiropractic neurology through the Carrick Institute for Graduate Studies. His training and personal experience allow him to evaluate and rehabilitate people from a brain-based perspective. He and his team use cutting-edge equipment and years of experience to test and interpret specific brain and nervous system markers. From these tests, they design treatment plans, integrating treatment tools and modalities to harness neuroplasticity. Daniel's involved in research, technology, consulting, and continued learning in these fields. His goal is to bring awareness and restore hope to people who are suffering from vestibular function but have yet to find answers to help them recover. Welcome, Daniel.
Thank you. So glad to be here.
And Brian Cashin is also with us today. He is an anesthesiologist, also from Toronto, Canada. In 2016, he was diagnosed with mycotoxin illness due to chronic exposure to mold, systemic candida, bilateral vestibulopathy, and oscillopsia. After therapy for his environmental illnesses, including antifungals, binders, gut restoration, he was able to start vestibular rehab. He has been working with Dr. Demian since March 2024. And in conjunction with that, he has also worked with an ENT and a kinesiologist. He is continuing to improve and has been able to start playing pickleball fairly competitively and regain significant functions and activities of daily life. Welcome, Brian. It's really, really nice to have you here today.
Thank you.
So, Brian, we always begin with a little bit of a vestibular journey, and hopefully it's not too traumatic to go back into the dark ages, but can you tell us a little bit about yours and what were your initial symptoms? Right. And then how did you find out what your diagnosis actually was? Sounds complex.
Yeah, it was a pretty insidious onset. I would say probably predated 2015. It was I first noticed insomnia, and I noticed gradual weight gain, non-restful sleep, excessive fatigue, and then I started noticing a little bit of sort of unsteadiness. I had an incident where I was cycling and I went over train tracks and I couldn't gaze stabilize when I went over the train tracks, and then gradually veered off to one side and fell off the bike. Not in a traumatic way that I've hurt myself, but I was able to get back on the bike and continue. So it wasn't a persistent thing. It happened that one time.
Hmm.
And I kind of ruled out at that time metabolic causes like hypoglycemia or hyperglycemia, cardiac arrhythmias, and had a stress test, which was normal. So I ruled out with the standard things that could cause um, imbalance. I wasn't sure if it was a cardiac issue. I couldn't really describe it. I sort of lost gaze and unable to stabilize, didn't know where I was in space and time when I went over the bump, essentially. And that led me to, when all those tests were negative, an ENT evaluation at my local ear, nose, and throat surgeon from the hospital. And at that time, they found some low level hearing loss on the left side and a um, left sided vestibulopathy, and they couldn't explain it. And then things kind of progressed from there to over the insidious months, I got progressively worse with actual frank vertigo, um, getting up from a sitting position. I felt like a disequilibrium, and it was um, culminated by almost like a drop attack that I had at one stage.
Mm.
At that point, my local ENT guys were also finding weird symptoms. Like whenever I pushed on my ear, I had nystagmus, so tragus-induced nystagmus, and that led to more investigations like a CT scan and MRI, which were negative. There was no CSF leak or anything else that could explain those weird neurologic symptoms. And saw a neurologist as well to rule out MS, and there was nothing suggestive on my MRI to make a diagnosis of MS. And then it got really bad, where I couldn't work because I had such strong vestibular symptoms and vertigo. And I was able, through my local ENT guy, to see an otologist at our tertiary care center in Toronto at the Toronto General. He's a primary otologist that has access to more advanced testing. And at that point, he came up with a diagnosis of oscillopsia and bilateral vestibulopathy, as well as um, a diagnosis of atypical Meniere's disease based on the fact that I didn't have the EMG findings of typical Meniere's disease. At that point, he said that it probably wouldn't get better. It would, there's not really any treatment for it. So he gave me Circ, and I took some lipoflavonoids on my own, and gradually I felt that it was unsafe to be in my house because going downstairs was challenging from a gaze stabilization perspective. He did not think I was impaired enough to miss work, although I felt unable to work to my full capacity, although I was still able to work. We eventually, because of my house had very steep stairs, I eventually sold my house and moved out. And that point, when the people involved, the real estate, the house was checked for all sorts of stuff by the inspectors, and they didn't find anything. I didn't even think about mold at that point. I just knew I couldn't live in the house because, I couldn't negotiate the stairs. So we bought a condo, which we subsequently renovated, and we were living in a rental. And at that point, I think I started to feel a little better, a little clearer headed, and I felt maybe there's an environmental factor. And coincidentally, the people that renovated the house said that under the deck they had there was a lot of mold, like a huge amount of mold. And the year or so before all this happened, I had done a renovation in the bathroom, and they still stored a lot of the building supplies underneath the deck where the mycotoxins were probably being disrupted by and carried into the house and then recirculated throughout the house. And it was the original HVAC system. So I suspect what happened was it was a culmination of um, although this deck was outside, the mycotoxins were dragged into the house, and then gradually over time, it just affected me in an adverse way. And so it wasn't until I moved out of the house that I started to realize maybe there's an environmental factor, and then that's what began the next phase of investigations after I had a diagnosis, to understand if there is an environmental factor involved in seeking another healthcare provider to sort of figure that out.
What a long, trying period.
And it
Yeah,
seemed like a perfect storm. I mean, it wasn't just one thing. There were so many things going on. And we know that that really complicates the diagnostic process. I mean,
yeah,
it's especially when I hear, I mean, the mold is kind of this thing over here. You know, it's not necessarily related to the vestibular problems, but you're probably not going to get better. You're not be able to deal with the vestibular problems while you've got this thing going on. But then to, you know, to differentiate between even atypical Meniere's and bilateral vestibulopathy or bilateral vestibular hypofunction, because they're so different, you know. And it sounds like that was probably part of the challenge in your diagnostic
yeah,
process, and later, as we'll discuss with Daniel, your treatment.
yeah. It was. I think if you look at oscillopsy itself, usually it's something finite structurally or otolithically toxic that's causing it, and and I think, as you said, the bilateral hypofunction was red herring, and mold, as you know, can present when different, so many different symptoms can be associated with mold toxicity, and depending on the patient and their biology, I guess, really depends on what's going to happen. Um, in this case, my brother had Crohn's disease and had seen a naturopath, and so he had mentioned that if you're thinking about an environmental cause, maybe you could go to the naturopath and ask her. And as it happened, the naturopath in Toronto, this one, she actually had experience with mold and was involved in some patients who had it. At that time in 2016, there weren't that many tests that you could do for mold that were diagnostic, and they were still controversial. And some people are lucky, with mold, they just leave the environment and they get better. Some people are colonized, and then you're colonized with it.
Hmm.
It's a much more involved process in terms of eradication. And in my case, um, I was colonized with it. At least that's what I had assumed, anyways, as I went through the treatment. And the treatment itself is difficult to adhere to, and it's also in Canada. It's hard to find all. Luckily, I'm medical, so I knew the compounding pharmacies. I knew where I could get stuff, and I also, at that same time, through my naturopath, joined the International Society of Environmentally Acquired Illnesses. And so I was able to go to their conference, and I was also went to the American Academy of Environmental Medicine conference. So I didn't really know enough about environmental illnesses. It's sort of out there, but real science, but it's more, again, on the functional end of medicine, which in Canada is
Sounds like a
sort of,
really scary episode of The Last of Us.
That's an interesting segue to talking about functional medicine and how you got connected with Dr. Demian. So, Daniel, most people, so you're a chiropractic neurologist, and most people have heard of a chiropractor and may assume that a chiropractic neurologist is basically the same thing. But how are they different?
Yeah, so both are licensed chiropractors, but chiropractic neurologists have a postgraduate training of in neurology of over 300 plus hours, depending on the subspecialties they would do underneath that. Traditional chiropractic is also quite joint and spine focused, often delivering adjustments, those kinds of things. And what chiropractic neurology would also look at is, in addition, the brain and the nervous system and the sensory integration of pathways, and potentially how you could even use information from the body to change how the brain and nervous system are integrating that information. And so, what it does is it tries to leverage neuroplasticity to restore and improve function using may be able to use rehabilitation therapies, eye exercises, sensory integration, but not just adjustments. So it's the training and also the diagnostic lens and testing they would use, but also we would look at different specific therapies that could include adjustments, but be much broader than that as well.
Brian, did you know about this chiropractic neurology before you met Dr. Demian? I hadn't even heard it myself. So,
A little bit. I had met a physician, a chiropractor named Dr. Horseman, Ian Horseman, who happened to be out in Peterborough, and I actually saw him kind of early on. I had seen when I was diagnosed with the vestibular dysfunction. I went to see a regular vestibular physiotherapist in Toronto who's very, very good. And they did videotape my eyes and I could see what was going on. And I did some of the exercises, which were helpful to a point where I didn't need to go to the Toronto General for any vestibular rehab. I was able to do it on my own. And that led me to this chiropractor, but he was learning on the fly because he was a bit older. He had been in practice doing conventional chiropractic treatment and then branched into this and taken a lot of courses on his own and was good. But it was kind of far going out to Peterborough. That's about an hour and a half from Toronto. Initially, when I went there, I couldn't even drive myself. My wife would drive me there. And then I got better enough just with detoxification and some my own rehab that I could drive to the appointments. At that stage, I felt it. You know what, I could do a lot of it on my own, and I put that on check. It took quite a long time metabolically to get better because after I cleared out the mold that I had still feeling unwell, and I had systemic candidemia. So that was diagnosed on a PCR testing, and then I had to. That was during COVID. So fortunately, I wasn't working full time because we were all sort of sequestered. So I was on high dose fluconazole for 6 weeks, and I used ozone therapy as well to help eradicate that.
so I want to steer us back to the neurology, though. I'm really curious since that's sort of the theme today.
Right.
So many layers. So it sounds like you didn't know about Dr. Demian, but you had sort of peripherally
I
heard
had an
it.
idea of it. I kind of bumped into it through a mutual, I would say, associate of Dr. Demian is David Steller, who's environmental expert in terms of remediation and house and indwelling remediation as well as diagnosis. And I saw their website. He was speaking, and then I realized that what they were, and they are very close to where I live. It's a fluke actually, and I sort of by accident bumped into it essentially, and I felt I was well enough at that point to potentially embark on it. I wasn't still acutely toxic at that stage, and I was in a headspace that I could challenge my vestibular system to try to improve.
And actually, the talk I was speaking at that time was the vestibular and the consequences of chronic illness. That was kind of the talk, and a lot of the crossover that a lot of those patients had identified with a lot of these issues, but couldn't understand how or didn't know how to put those things together. So that was how I think it was at that talk that Brian had heard. And
Yeah, exactly.
sometimes patients we get a label, and we kind of put other like our vestibular issues on the back burner for all these other things, but don't always realize how they're so interrelated with the nervous system and how it functions.
Yeah.
Well, that is actually a great segue. So when we've talked before, Dr. Demian, you've said that you usually get the complex patients that have seen everybody else and just haven't been able to really feel fully better. Can you maybe describe your typical patient's journey, how they find you, and then, the process of you getting to the root of what's going on for them?
Yeah, I mean, one thing I'd say is there a typical patient, right? Every patient is uniquely atypical, but as you heard from Brian's story, but like for instance, where we kind of sometimes with even like let's use chronic illness as a background is where we get left off is these kind of Venn diagram of different kind of symptoms within the vestibular space, the autonomic space, the cervicogenic space, all these different kind of spits. So I'd say, I mean, two ways. One, I often see patients who are similar to Brian, where they've gotten better on different steps of their journey, but there's a function that is not gained in the last part. Or I can see patients that have not gotten better, or there was a missing piece along the way that was a primary issue that needed to be addressed before they could rehabilitate other things as well. So I'd say both of those. I'd say, often patients will have seen multiple providers in conjunction, or I get them and I'm sending them back when they're making those improvements. They often will have seen ENTs or neurologists or just been referred from their family doctors, those kinds of things. There are a lot of patients within the functional space, I would definitely say, or a lot of patients also in the crossover with the cervicogenic spaces as well. There's a cervicogenic or neck-based aspect to their dizziness. Sometimes they're atypical. They're not classic vertigo, or not always the same classic vertigo, because of there's sensory issues within the visual system, the vestibular system, and the spinal or cervicogenic system specifically. And it's just the way they're integrating. They're all slightly poor, but the brain's always trying to choose the best information. So they may not appear like in our, classic, what we love to see the textbook black and white box. They're not always that way. So imaging and basic vestibular tests may appear normal, or it may be abnormal. It just may not follow a typical pattern that we're used to seeing, because it is so dynamic with how the brain and the nervous system are choosing, or I say choosing, but we call that sensory weighting. It's trying to choose the best sense to use in a specific scenario. Some have tried medications or typical vestibular rehab, but symptoms persist, and that's often where they will come to us. We typically will start with a detailed functional assessment, create an individualized rehab plan, trying to target their weaker or the dysfunctional neural pathways or sensory integration pathways, and then we'll use treatment-based, both in clinic, home exercise plans. Some of it's often because it is the brain and nervous system, can look like different spheres together. So vision, or eye movement, vestibular, a huge amount. Some of it can look like habituation or vestibular rehab, and then manual therapy is also a big part of that as well.
Sounds very comprehensive.
Before we go on, you keep mentioning functional, and I wonder if everybody who's listening understands what functional medicine is. Can you explain that a little bit?
Yeah, well, functional medicine itself is a specialty. Let me differentiate. So,
Okay.
functional conditions, functional medicine is an approach to medicine. It's not actually my specialty, but often with patients we'll go through that. functional medicine's approach to medicine that I think they would best describe as root cause medicine. So not just looking at the label or treating the symptoms, but looking for the root cause and working through that. Functional disorders or along the functional spectrum often are things that we cannot find the structural basis for or fit an inconsistent pattern. There are specific diagnostic criteria that are being formed, but something like PPPD or P3D, sometimes it's called, would be a functional disorder. Sometimes we can think like atypical Meniere's. Sometimes even vestibular migraine can show some functional symptoms. So they're changing their different aspects. They are not a structural lesion per se, as we typically think about it.
I think it's interesting, Daniel, that you were saying that a lot of cervicogenic patients also end up with you. I was initially misdiagnosed with cervicogenic vertigo, but like you said, I didn't fit the classic where, if I move my head forward, I get dizzy. It was like I'm dizzy all the time, guys. Like there's nothing changing this here. But I did visit one of the cervicogenic chiropractors, and it was all manual.
Mm-hmm.
Which was doing nothing for me. So I can appreciate that, you might have those patients and then you're applying a lot of different modalities, not just the manual therapy to try to fix, because I would imagine that doesn't typically work.
Yeah, I mean, identifying your patient is so, so important. It's the first step. Sometimes it's not me. I'm not the primary person, right? And that's why they've maybe made a lot of progress. Sometimes there is a component of that needs to happen, but there are some things that need to be improved before. Like that's the case for sure. In Brian's case is I know that I'm also getting to see him, as he's farther along his treatment journey. But there are tests that can better identify if there is not just a cervicogenic dizziness, where it's just like that is your primary diagnosis, but if there is a cervicogenic or proprioceptive component to someone's dizziness, that can also be the aspect. You can have, chronic BPPV, which is a very structural, or what we typically think of as a classic type of dizziness in a certain canal plane, and as a result, your neck and myofascial system, the muscle tension is increasing. That does not help, right? Headaches are also, but you can also develop overlapping conditions, which is really, really common. So it's also great to be able to work within a team, but also say, yeah, it's not just manual therapy. Once you have treated a person, it's also what we look at is also important to then say, now how are we helping the say, for instance, in this scenario we're using, it's not the only one, but the neck is functioning better. It has better proprioceptive and sensory motor integration. How are we now integrating it with the visual system, the vestibular system, even like the individual parts, the otolithic is highly integrated with that. So maybe that's how I answer that question.
Yeah, absolutely. I should have gone to you. That's what answers the question. Brian, when you first visited Dr. Demian, you had already been to a lot of practitioners. How was his approach different?
Well, first of all, I kind of knew of his training in the sense that we have a very famous Canadian hockey player who was out with a concussion, thought his career was over, and saw what Dr. Damian's instructor, I guess, or professor, and cured him. And that was almost remarkable because most people thought his career was over. And so I had known that he had exceptional training above and beyond anybody who's going to have that. There would be no one that I knew of, at least in the GTA. And Toronto's a fairly big city, 5-6 million people. So there, very few people have his degree of training. I was lucky the fact that he moved from Vancouver to Toronto, and that he was in a supportive environment with other colleagues who saw patients of similar conditions, because it's a very hard thing for him to practice individually on his own. As we talked about, it's an integrated process with we need a team that has experience, and he had that team around him. So it's one thing to see someone who has the training, but they may not have seen patients with that. They would have seen patients with that diagnosis, but they may not have seen them in various phases of their treatment. So that tempers a lot about the diagnostic abilities of what they can or can't do. Because if you're so sick, you can't do even the most basic diagnostic tests that he would perform on me, which are, not stressful, but they are taxing on your vestibular system.
Mm-hmm.
Just, standing on an unperturbed surface, recording your eye movements in the dark and with in the light, um, and then measuring very precisely all the what different head movements do and different stimulation and how that affects your vestibular function. That in itself would have wiped me out, and most patients, if they were at the beginning of their treatment. So his perspective is important. In other words, he sees patients who are at the beginning of their medical therapy or the middle or the end. I was kind of through at least 5 to 7 years of treatment before I saw him, right? And so I was at a stage I was lucky. It was the intersection of being at a medically ready stage to be able to accept um, vestibular therapy in the sense of be up and beyond what would be considered basic, and he has all the tools that are used for diagnosis, even be above and beyond the otologist that I saw. He Because he's working with the vestibular system and the brain and the spine, he's able to integrate all that. Whereas the otologist really can only integrate the otolithic system, and that can't really bring into it the brain and the spine. So he's at a huge advantage from being a functional practitioner to be able to integrate that, and has the tools both from a diagnostic and from a therapeutic standpoint to be able to bring all those things together.
Mm-hmm.
So I don't think in our Canadian um, chiropractic therapy, I don't think there are very few. There are very few subspecialists, and that's what he is the subspecialist of chiropractic therapy that um, have that expertise. So you have to almost go to the States to get that expertise. You can't get that I don't think you can get that in Canada unless you're taking courses. But the courses you're taking are driven by professors, usually in the States. We just are small. Canada's only, I know, I think you're aware of our size. We aren't the 21st state yet, 51st state yet, but we are
No.
a tiny. We're a
I hope you never are. You guys are better than us, so stay that way.
We're big geographically, but we're small from a numbers perspective. So Daniel Mace, I can't speak for him, but I'm sure he gets a lot of inquiries from outside around other various parts of Canada, and
Yeah.
people may come to see him and spend some time in Toronto getting their therapy. I'm just very, 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 very lucky that I bumped into him at the right time, and that he's really almost walking distance from where I live.
Oh my goodness.
Yeah, it's that.
Very
It's that.
lucky.
I'm very lucky. I mean, it's just, I'm lucky. That's all I
Yeah.
can say.
It's
I'm
both your
lucky that
specialized. I was
What's
going to
that?
say it's both Daniel's specialized training and the fact that he works in a multidisciplinary clinic. I think that really makes a difference.
100%. I think that's the only way you can really practice it effectively. And they're lucky. They have fantastic medical physicians, fantastic naturopaths, and fantastic therapists that work there. And they have all the equipment. Like, it's not like they've spent a significant amount of money to equip their clinic with state-of-the-art diagnostic and therapeutic equipment, and they know how to use it. Like this
Right.
isn't like this is really it's not it's amazing actually what they've got and when and the space that they have and they only I think it's not been that many years that they've been able to ramp up and do this. So for I was just lucky, I guess, and
Yeah.
you know, and I'm happy and grateful that I could participate in some therapy.
Well, we hope that other people are just as lucky and that they can find qualified specialists like Daniel. Now, Daniel, I know that I know you work primarily, or you work with a lot of vestibular patients. Are there, and as I said before, triple PD is one of those diagnoses that a lot of people come to you to see you for because it is so complex. You see a lot of complex cases. Are there what vestibular diagnoses can you treat? Do you normally treat? And are there any that are contraindicated for the type of work that a chiropractic neurologist does?
Yeah, I would say, of course, we do quite well with BPPV, even chronic BPPV. Vestibular migraine is another space that we co-manage and can do quite well with. Post-concussion dizziness is a space that we do
Mhm.
quite well with. Sometimes even orthostatic intolerance related dizzinesses, if it's not structural, if it's about spatial perception, that's a space that either we can work with in a team or do quite well with. So some that would fit within that dysautonomia type space. And then the uncompensated vestibulopathy, sometimes which I'll get to, is in the chronic stages of that where we're trying to regain function and regain their life, or even try to manage some of the long-term symptoms that happen from that. Those are some of the cases that we do best with. Um, Structural issues like vestibular schwannomas, active Meniere's, acute labyrinthitis, those are not necessarily the space that we're best equipped to see people, or we will refer those out at once identified and saying there needs to be an acute medical management. That doesn't mean we can't be, consulted as care goes on or we're totally out of the case, but that is a space where we often refer out. Obviously, anything vascular, that's a big one for us and a differentiator. Those vascular ones we want to one refer out with for medical instability, like sometimes even the comorbidities, of course, that kind of come along. The things that come along that people aren't a vestibular system in isolation. There's other things that come along with that. And then also rapidly progressing symptoms that don't fit a pattern that we want to look at. Those need referral. In these cases, we would collaborate, not lead the case.
Daniel, can you? I'm hoping I'm not the only one. Maybe you could explain, just give us a concise example. And I know maybe this is really hard to do, but let's say somebody comes in and you're like, okay, there's some proprioceptive or spatial dysfunction happening here. Can you just give us a little example of what you might do for them so we can really understand how this is different than just traditional vestibular
For
therapy?
examination and testing, or for treatment?
I'm for, well, I mean, both, but maybe treatment wise, I think.
I I think, yeah, I think
Or
both
what do you
too,
think,
because it
Cynthia?
sounds like you do. That's one of the things that differentiates you is how much uh, testing you're involved in. Is that
Mhm.
true?
Yeah. I mean, we do. I am lucky enough as Kimberly was saying before, the specificity of the diagnosis is important to us. We want to know what systems are involved, what the general area is. So for sure, the testing is important. We're also lucky enough, and we purposely sought out equipment that would help us objectively measure and test. So eye movement tracking, both with targets and with nothing. So VNG or VOG, video nystagmography or video oculography, is something we use quite often. Posturography, so static and dynamic balance under different conditions. So like a sensory organization test or the CAT-SIB, those are helpful in understanding which systems are involved. I'm lucky to also work at a clinic where there's lab testing available for me, or there's referrals out, or imaging. That's not stuff we would do in house, but those are kind of some of the main things that we'd be testing, as well as our clinical and neurological examination. We will, obviously, in our space, we'll run everything from neck range. Well, obviously, the history is our biggest component to it. Understanding what the patient's journey is, what's the diagnosis, what tests have been ruled out certain diagnoses, and then also in our what things make them worse and what things make them better. That is a huge thing for us. So sometimes, patients will even just is there a position that you feel worse in, and sometimes differentiating that with, is that if I say, hey, when I'm laying back and my head's turned to the right, that's a pretty clear or a very good indication of a positional test, provocative test for something like BPPV. But their neck is also torsion in that test. Is there ways that we can differentiate or separate one from the other? So there's something called a neck torsion test or a cervical torsion test. You can do both, looking for nystagmus, also looking for balance and dizziness issues, which you don't actually move the head. So the body moves so that the neck gets torsioned. I can't do it in this chair, but the neck gets torsioned, but the head stays fixed. And so the vestibular system shouldn't be activated there. And if someone increases their dizziness, we start to clinically think about, okay, the neck is either a part of, or this neck and spine are either a part of this, or cervicogenic dizziness might be a clear one. There are tests that test how well the proprioceptive system's working. So cervical joint position air test, which has clinically validated guidelines of someone's wearing a head laser, or they're pointing their head straight ahead, they close their eyes and they try to find neutral. Again, do they know where they are in space? There are other ones that we look at smooth pursuits in neck torsion. So we have a clinical test, battery test, but sometimes someone will feel in a cervicogenic dizziness case will feel better just by giving a neck hug. And we say, oh, does that make you feel more still? And they say, yeah, it does. Or no, that actually doesn't change it. Or they get better proprioceptive leaning against a wall or giving better feedback to their system. In a vestibular patient, you ask them to lean back, mostly the BPVs, you made them so much worse. In a more of a proprioceptive cervicogenic case, you might make them a lot better. So we get a lot of feedback just by screening some tools. Not every patient makes it that easy on you. You sometimes have to dig harder, but there is a battery of tests that would help us get a sense of some of those things. So
wow, that's fascinating.
Yeah, maybe that's on the examination side. There's a whole host of that would bore everybody if I went through every test, but those are some of the ideas that we try to tease apart the different systems. What happens when you close your eyes? What happens when you open your eyes? What happens when your neck is torsion but your vestibular system isn't activated? What happens, and vice versa? If I keep the neck fixed and I just put you in a position, does that trigger you or not? Then treatment wise, it really is there's a specificity and a dosage aspect of that we have to be careful of. And then there's a prioritization of different sensory systems as the issue. And so sometimes it does, let's say using a simple standard case, it is manual therapy, but right after, when they're like, oh, I feel a bit stiller, we're then retraining with gaze stabilization exercises, or we're challenging or we're now putting them in habituation type therapies, or we're using visual motion in front of them when they can tolerate it, or they're using the right sensory system to compensate for that kind of thing. I hope that answers a little bit.
Yeah, absolutely. And I imagine that I would say the majority of vestibular patients have never had any of those tests. So it's very reassuring to know that this type of work exists, because I think sometimes it does need to be that parsed out. So that's exciting.
Yeah.
I think it kind of reiterates what I was saying before, that it's the complicated patients, that it's not one thing or it's not something that is easily identified. So there's a lot of testing of different things to identify the one or multiple causes, and also the fact that, as you said, Dr. Demian, before, all the systems are integrated, It's not just the inner ear, it's not just the eyes, it's not just the nervous system, but being able to look at it from all of those perspectives.
Mm-hmm. Yeah.
Yeah, and in Brian's case, a neuroinflammatory, let's maybe think potentially a neuroinflammatory cascade has led to a decompensation of those systems, and now we're looking to say, often in this case, it's kind of like, okay, this has all happened. How do we rebuild? How do we retrain that system to be able to switch and adapt?
Yeah. You're almost doing detective work. You should have like a little detective hat and pipe. Brian, after all of this, and I'm sure imagining a lot of tests and a lot of different types of treatments with Dr. Demian, did you start to feel a turning point where things were getting better?
Well, when I got to him, I was already um, systemically better, I guess you could say. And I was able to, that's when I had already been maybe 6 months into starting to play pickleball. Like I hadn't actually done any, I was able to work out to some degree, but you can imagine if you're trying to gauge stabilize a lot of the day and you're working, that you would have a fair amount of fatigue by the end of the day. So you would have to rest before you would exercise. And then if you put a sport where you're actually tracking a ball and you're tracking a ball that moves pretty fast, I was able to start to do that. So I've realized, okay, I must be getting better now. Um, and I kind of bumped into him. It's like two people walking on the street that sort of just I bumped into it really. Like it was no other way around it. It was like I wish if I had known about it um, earlier, I would have when I was systemically better, I probably would have engaged in it sooner. But I didn't. So um, hence why I'm speaking right now, just so that people have some awareness about it, so that um, people know that they're, I mean, I think a lot of your patients and yourself included probably felt a bit hopeless at one point because of diagnostic dilemmas, breaches in um, um, sort of finding the right practitioner, siloed medicine, as they say, all these things. So I was lucky. I can't, it's sort of, I wish I had been more proactive to look for this, but their practice is relatively new as well. So it just worked out for me. I mean,
And maybe if I add to that, Brian, is that
yeah,
it was a journey. Like Brian was statically okay, but as soon as we challenged him in vision challenge scenarios, or we challenged the ability to use this proprioceptive system, or to compensate, it would start to he would really have some issues, and he's worked really hard on improving those. We saw a lot of when we did eye tracking through some different softwares is his ability to hold on to targets, both when he's just looking ahead and turning, was compromised. Really, a lot of improvement. I mean, he went from severely reduced categories and normative data to healthy balance in a lot. He's talking about pickleball. Sports are the ultimate challenge to these. Now, and I think that was a big part. It was like he was better, a lot better, but he wasn't as functional as he wanted to be. He wasn't living to the fullest. And that's where we really worked to saying, okay, well, if you wanted to play a pickleball, you got to track things. You got to know where people are. You got to be able to move and have things moving around you. And that's where we've really worked. And Brian won't brag about what his coach graded his pickleball skills, but it's quite a serious sport is what I understand. And yeah, so he's done, Brian's worked really hard at both in clinic, at home, trying to integrate things into his life and that kind of stuff. So we did see both subjective, objective measures, and then his quality of life, his ability to get back into things improve. And that was a big thing.
It's huge.
Awesome. Thanks for that. Now, Brian, I know you had said that you worked with a physical therapist previously, correct? Is that right?
yeah. Well, I worked with vestibular rehab. I've worked
Okay.
with kinesiologist who was aware of my issues as well. So she was
Mhm.
able to do some functional like training,
Mhm.
resistance training and we worked on balance as well and power and
Okay.
motion. So the idea is to use motion and head movement as well as integrating power. So
Mhm.
try to simulate these activities. So yeah, so I worked with her as well.
So
Hmm.
you had addressed some of those issues already. Now, Daniel, I think that's a great opportunity to explain how does what chiropractic neurology do differ from what a vestibular physical therapy would do, a therapist would do.
Yeah, I find that question sometimes hard because I don't want to speak. There's a there's heterogeneity, like people practice differently, that kind of stuff. But I would say maybe what a chiropractic neurology would more so do is have a more manual therapy as a bridge focus. That would be something that would be more specific. I would say vestibular physical therapy often traditionally has a focus on the peripheral vestibular system more as a solely focused, whereas maybe if you were to talk about it, it is part of what the chiropractic neurology thinks about and looks at, but also the central consequences of all that input and how it integrates is maybe a focus. And then I would say there's more of a traditionally more of a focus of habituation in compared to sometimes looking at uh, adaptation and sensory weighting in that system to try to have the different sensory systems integrate. Maybe is what I would say is less so a solely or more of a focus on the peripheral vestibular system and vestibular physiotherapy, whereas maybe chiropractic neurology could be thought of as to have more of a focus on the sensory integration of all those sensory systems.
Yeah, that's clear. I think, yeah, you've explained that well. That we are approaching the vestibular system through all the senses, and that's refreshing. So, Brian, I don't know if you have, there's some stigmas out there around chiropractic work. And I know that some people would be like, no, I can't do that. What would you say to somebody that might be feeling skeptical about chiropractic work, specifically chiropractic neurology? Probably don't even know about it,
I
but
think, yeah, I think they have to have an open mind. It really depends on where how where they want out of their own life, really, because ultimately the patient has to decide. You can only clinicians. You can't be passive about your health. You have to be active. And fortunately, some patients are very passive about it and expect the work to be done by the clinicians. So if you want to try to take your healthcare to the next level, and you're have an open mind, and I would say it's something to think about um, in terms of getting comfortable with um, a chiropractor gently maneuvering around the C spine and around the thoracic spine. That even for me, that's a little not nerve wracking, but I'm obviously aware of some of the challenges, and fortunately, Daniel's exactly the person who has that type of experience because he is so aware of, intricately aware of the anatomy and the physiology, and he's doing things that are already been shown on you to potentially have benefits. So when he does a procedure or a manipulation, it's because he's already shown that integration is required to enhance function, right? So he's not doing it nothing is done as a routine. It's does, as he said, on